J. Roy Rowland, Georgia's congressman from the 8th District, really doesn't need an introduction to followers of politics around the state. There is a bio sketch of Congressman Rowland at your table, so I'm not going to go into the details of his distinguished career. It's all there for you. But I did want to mention a couple of things, and I didn't want to touch over too lightly some of his main contributions, both in rural health care and veterans affairs, and bringing a positive, constructive end to the Nicaraguan war by forging a consensus compromise position there. But I did want to mention the most unique thing I think about Congressman Rowland at this point in time. He's one of 2 medical doctors in the United States Congress, the other being a psychiatrist. So he is in a unique position to understand what this healthcare debate is all about. And in so doing, he's forged he's co-authored a bill called the Health Reform Consensus Act of 1994 that has support from both Republicans and Democrats. And it's a good plan. He's going to tell us a bit about it today, but let me close by saying I think he's retiring at the end of this session. He's self-imposed some term limits. He's very popular in his district, but he's determined for his own reasons that he's been there long enough, and I think it's important, and it's almost a divine type of thing where a medical doctor like Congressman Rowland is an author of a health care plan that has such widespread support. He's a conservative, he's a consensus builder, he's a true gentleman, and it's my pleasure to introduce to you J. Roy Rowland.
Thank you very much, and may I tell all of you how pleased I am to have the opportunity to visit with you this morning about health care reform, and thank you for starting a little bit early. I can tell you that many members of the House are very uneasy and uncertain about health care reform. We had 5 ice storms in Washington this year. I missed 4 of them, but I was there for the last one. We were supposed to leave on Friday after adjourning on Thursday night, but the ice storm closed the airport, so we were not able to leave on Friday. On Saturday morning, when I went to the airport to leave, you can imagine the confusion with all of the people that were visiting in Washington, those there on business, and members of Congress trying to leave at the same time, and everybody was kind of edgy and uncertain. I was standing in a line to get a boarding pass, and the fellow in front of me obviously was quite tense, and the agent at the window was pretty well strung out by that time, too. He asked the fellow in front of me, he said, "You got any bags you won't check?" The fellow said, "Yeah, I got 3. He didn't like the way that fellow said that to him. He said, "I want you to send 1 to New York, 1 to Chicago, and 1 to Honolulu." The agent said, "I can't do that." The fellow said, "You did last week." So members of Congress are like that right now. They're very uneasy, and uncertain. I guess my feeling about health care reform is colored by what I have seen happen in health care delivery over the last 40 years. I had the opportunity to practice medicine prior to the advent of Medicare and Medicaid. I thought we had a pretty good system of health care delivery at that time, but there were those who thought that we needed to do something to improve our health care delivery system and the quality of care, and as you know, there are 2 federal programs that are in place now that attempted to do just that. The Medicare program and the Medicaid program. Medicare, of course, for the elderly, and Medicaid is a combination state-federal system to try to help the poor. That was a good idea, I suppose, but no one envisioned that those 2 programs were going to cost as much as they did. In fact, there's a story that goes around about Wilbur Mills, who was the chairman of the Ways and Means Committee at that time, had a staff person working for him. And President Johnson asked the staff person, "Well, how much do you think this Medicare program will cost in 1990? And he said about $9 billion. Well, you can see it was way off the estimate because last year Medicare cost $130.3 billion and Medicaid $133 billion. So I'm very concerned that if the federal government becomes involved in trying to remake our health care delivery system, we are going to wind up with something that will cost far more than is ever anticipated. No one can look into the future and tell what's going to be happening 4 or 5 years from now. While CBO and OMB does the best that they can in making estimates, they can't know what the unemployment rate and the inflation rate and the interest rates and the gross domestic product is going to be 4 or 5 years from now. So I think that we need to be very cautious in doing anything that is going to change about 1/7 of our gross domestic product to the extent that some people are talking about at this time. Not only that, but it became evident early last year that this debate on health care reform was going to take place in a very partisan political atmosphere, which was very disturbing to me. I think that anything as big as changing health care reform needs to be done with people working together on both sides of the aisle to try to achieve that. But that is really not what has taken place. Mike Billericus, who is a Republican from Florida, and I came to the House of Representatives at the same time. Mike and I have worked on some health care related issues over the past 12 years that we have been in Congress, and he also was very disturbed about what he saw taking place as well. Mike had the opportunity to ride back from Tampa last year on Air Force One with the President when he went down for a meeting there. And during the course of a conversation with him, asked the President if he would be receptive to doing things that could be done in the event that his legislation, which was being proposed at that time, was not received favorably, and he said that the President indicated yes, he was willing to do that. So Mike and I got 102 signatures from both sides of the aisle on a letter and sent it to the President, asking him if he would do exactly that. Well, we received a very firm no back from the President. We wrote him another letter and told him, just Mike and I signing it, that we were going to proceed to try to find some way to do health care reform in those areas that needed some attention. Now, I think we've got the best quality of health care of any country in the world. We are preeminent in medical and pharmaceutical research. There is no country in the world that exceeds us. I think that about 85% of the people in our country are pretty well satisfied with the health care that they have. I know that in the district that I represent, that is the case, and having practiced medicine for the number of years that I did, I believe that to be true as well. So there's part of our system that is working well. Let's not tamper with that. Let's not try to change that. Let's look at that part of the system that does need some attention and do that, because we do have some problems in our health care delivery system. There's no doubt about that. So Mike and I begin to think, how are we going to do something and do it on a bipartisan basis, and what is it that we can do? So we thought if we looked at those pieces of legislation that were out there and found a common thread among most of them, and there's 6 or 7 pieces of legislation out there, and take those things upon which there seemed to be general agreement and put them together in one piece of legislation, that would be a good place to start. It just seems logical, doesn't it? If you start at a place where there's general agreement and build on that, rather than start somewhere that there's a great deal of disagreement and downsize it. I know when I presented this plan to Ike Skelton, who was a member from Missouri, Mike looked at me and said, "Doc, it's a good idea, but it won't pass." I said, "Why, Ike?" He said, "It's too logical." You know, and I guess that's the way that things are looked at sometimes as being too logical. But I think that those people who really oppose it believe that if we do the things that we have proposed, we may not do anything else, and we won't reach universal coverage, whatever universal coverage is. But Mike and I, along with our staffs, we worked for several months getting together those things that there seemed to be general agreement. And you've got this piece of paper on your table there that kind of outlines the things that we said ought to be a good starting point. Insurance reform. Now, I won't go into the details of this, but Jerry just very briefly mentioned to you that there is a problem when individuals want to move from one job to another, that they lose their insurance coverage. And if they've got some kind of pre-existing condition, they are not able to receive the coverage when they move to another position of employment, and they have job lock. That ought not to be true. People ought to be able to move from one place to another without having that to happen. There's fraud and abuse legislation as well. There's a significant amount of abuse of the present systems that go on out there. In fact, a lot of abuse that has taken place in the Medicare and Medicaid system is one of the reasons that they cost as much as they do. And I'm sure that you are quite aware that those two programs do not pay for themselves now, and the cost of that is shifted over to the private sector, and that has something to do with the cost of care going up in the private sector as well. Some malpractice reform was a common thread as well. We looked at doing an alternative dispute resolution. This was a common thing in those pieces of legislation that were out there before an individual goes to trial, and they still have the opportunity to go to trial if they want to. Some administrative simplification. Now, I guess if there's one thing that I hear as much about from providers as anything. It is the fact that they're absolutely loaded down with paperwork, and they have to hire additional people in order to administer all the requirements that are placed upon them, rules and regulations by HCFA. Antitrust legislation as well. If people in a community want to get together and find a better way to deliver health care, they ought to be able to do that without being worried about violating the antitrust laws. We have to be careful in not going too far in that direction, but there was some general consensus that we ought to have some antitrust reform as well. So those are some of the things that we found to be common in those pieces of legislation that are out there. Well, what about universal coverage? I'm not really sure, as I said, exactly what universal coverage is. We say we've got full employment when we've got 5% unemployment. We know that Hawaii has employer mandates in place there, and yet only 92% of the people in Hawaii are covered. So I'm not really sure what universal coverage is. Is it covering 95 or 94 or 93% of the people? I haven't really heard that defined definitely at this point. You know, the president took his pen and said, I'm going to veto any piece of legislation that does not provide private insurance coverage for everyone that cannot be taken away. Well, I believe the president would be hard put to veto legislation that would do something to improve the delivery of health care in the system that we now have. So I just do not believe that. I believe that he's a good politician, and he will be receptive to signing legislation that does that. But what about universal coverage? We do not try to achieve universal coverage in what we have proposed. Now, this is an idea of ours that is separate from the legislation that is out there that we felt to be a consensus, although several pieces of the legislation do mention community health centers. I'm a strong advocate of community health centers. I've seen how well they work, how they do a really good job very effectively and cost efficiently. There are more than 1,200 community health centers in our country now. I have 2 in the district that I represent. We have just over 20 in our own state of Georgia. So we put together some legislation to try to expand the number of community health centers to reach as many people as we could who are uninsured and underinsured. And we don't know how many that'll be. But what we say is, let's try this. Let's see how many people we can reach. Let's do this for 3 or 4 years and get a good idea about how well this is going to work while we continue to debate the issue of universal coverage and how we're going to pay for it. I don't really know how much universal coverage will cost. I don't think anybody knows that. But I do believe that it will take an adequate amount of money if we say exactly what it is that we want to cover that we don't have. We don't have that money. We're going to either have to borrow the money, which will increase our deficit, or raise taxes in order to finance it. And we will do some things that we really should not do, making cuts in some other programs. Medicare has been under the gun ever since I've been in Congress, insofar as the amount of money that is spent on that program. And I've already mentioned far more than was ever anticipated. But we've gotten into that situation. Now, in trying to meet our budget deficit problem, in the process of reconciliation, we've cut Medicare every year since I've been there. As I mentioned earlier, to the point where it doesn't even pay for itself now, and the cost is shifted over to the private sector, and we're talking about doing more cuts in Medicare. It just doesn't make any sense to me to do that, because we're going to have it pay for less than what it is already paying for, and it's going to cause more problems. What has happened now, HCFA, Healthcare Financing Administration, in order to hold down the increasing cost of a Medicare program, has monitored the delivery of that care more and more to the point that it is now micromanaging the delivery of care. I know you must hear that from physicians and other people who provide care, that HCFA is actually interceding between the patient and the physician. And I believe if you have more cuts in Medicare, you're going to have more of the same kind of thing to happen. You're going to have more micromanagement of the delivery of care to the great detriment, and we will see the quality of care begin to deteriorate in our country. But we put together this piece of legislation to create an additional number of community health centers in our country without asking for any additional money. we believe that there is enough money in the system now to expand the number of community health centers that we have in our country. And let me very briefly explain to you about community health centers. Well, let me talk about insurance just a minute and talk about purchasing insurance for everybody. It's a good idea for everybody to have insurance, but what good is insurance if you don't have somebody to provide the care? I mean, that's a real problem. We have 3,300 counties in our country that there are no health care providers at all. And in many inner city areas, there are not an adequate number of providers there. So even if you provide the insurance for the people, that doesn't mean they're going to get the care. Under the Medicaid program, everyone was supposed to get the care, but there are many people who are eligible for Medicaid that don't receive Medicaid, and there are many who have it don't really utilize the services that are provided to them. So what we did was to try to put in place these community health centers and expand them in the areas of our country where there are no health care providers and see how well that they work. Each community health center must have a relationship with the hospital because an individual may need more than outpatient care. They may need to go into a hospital. So we created in our legislation what we call community health authorities. It is made up of a hospital and maybe 1, 2, 3, or 4 community health centers, depending on how many that hospital feels that it can deal with. People who work in community health centers work on a salaried basis. They work on a contract basis. Now, I as a doctor can order a test that I need on a patient, and I can order 3 or 4 that I don't need and can justify. Unfortunately, there's a significant amount of that goes on. A good bit of it goes on because of defensive medicine, but then there is a significant abuse of the system as well. We have the federal Medicaid money come back to the Community Health Authority on a capitated basis, so that removes that incentive for gaming the system. We think there will be a significant savings there, and congressional research tells us that there will be a significant savings as well. Anybody can use a community health center and pay based on their ability to pay. They pay based on a sliding scale. If they're able to pay the full fee, they pay that. If they can pay only part, they pay only part. We give the states the flexibility to say to the Medicaid recipients, if there is a community health center available for outpatient care, you have to use that community health center and not go to the emergency room of the hospital. You know, it costs 3 or 4 times as much to go to the emergency room than it does to go to the doctor's office. CRS tells us there will be a significant savings in that as well. We give the states the flexibility to put in place as many of these community health centers as they feel like they would want to and do that at their own discretion. The other funding for community health centers would come from the state Medicaid money. Now, I believe that if there is a local government where there is no health care facility, that the chairman of a county commission, for example, would jump at the opportunity to be able to tell the people in that county, we're going to put a little money into community health center, we're going to get some state and federal money, and we will have a health care facility in our county where anyone can go and get their health care. I think it'd be a great thing for them to be able to do. Then there is money on the Public Health Service Community Health Center Grant Program, $600 million at this time. And then there are various foundations out there that make grants for community health centers as well. So it just depends on how smart the governing board of a community health authority is, which is made up of a cross-section of the people who live in a community, and at least 51% of them must be patients in that community health center, not to tell the doctor how to treat pneumonia, but to let them know how well it's running. But we think that we ought to put something like this in place. Let's give it a try, see how many people we can reach who are uninsured and underinsured while we continue to look for a way to finance universal coverage. Well, what's going on right now? I'll just give you very quickly what I see is going on. It's changing almost daily. As you know, it has starts and stops. It looks like a little bit, nothing much is going to get done, and then it moves ahead again. I was saying earlier, if there's anything certain in politics, it's uncertainty. So, you know, we just have to see what's going to happen. There are already 2 committees that have reported out bills very similar to what the president wanted. The Human Resources and Labor Committee on the Senate side, and the Labor and Education Committee on the House side. The Ways and Means Committee has met over the weekend, as I'm sure you have read, to try to report out a piece of legislation. Sam Gibbons, who is now the acting chairman of that committee, is a person who would push something like the president wants if he has the opportunity. Dan Rostenkowski is a vote counter. He would not report out anything that he did not think had enough votes on the floor of the House to pass, but at this time he's not in charge of the committee. On the Senate side, the Senate Finance Committee, there's been a group of 8 or 9 members there from both sides of the aisle working to try to put something together, much less than what the President had wanted. No employer mandates, no individual mandates to present to Senator Moynihan. And you know, Senator Moynihan is really an uncertain kind of a guy in my mind. He's one place one day and another place the next day. But he's, I understand, is proposing to present something today that will not have employer mandates in it. It remains to be seen what's going to happen there. Many of us have felt that probably the Senate Finance Committee would write the kind of legislation that may be used as a vehicle on the Senate side and have a great deal of influence on the House side as well. Now, I serve on the Energy and Commerce Committee, which has a subcommittee on health and environment, which deals with all health care legislation on the House side except Part A of Medicare, which is the hospital portion of Medicare. We're in a deadlock in the Energy and Commerce Committee. John Dingell, who is a great chairman, has introduced every year since he's been in the Congress, every Congress since he's been there for 40 years now, a piece of legislation that his father wrote, who was in the House before John Dingell came there, and it is to federalize our system of health care in our country. And he is sticking to that. He told me just a week before last, said, Roy, I'm going to tell you, your legislation is going to stay right in that committee. It's not going to go anywhere. And he has the authority to do it. He has the power to do that. The person with the gavel has the power not to bring up in committee any legislation that they do not want to bring up. I am convinced that if the legislation that Mike and I have proposed as a starting point would have come before that committee, it would pass out immediately. And I am convinced that if it would have come to the floor of the House, it would be the vehicle of choice in order to try to move health care forward, and I think the leadership of the House believes that as well, and they're going to try to keep us from bringing this legislation to the floor. It's obvious to me that we're not going to get anything out of the Energy and Commerce Committee now. There are 44 members of that committee, 17 Republicans and 27 Democrats. None of the Republicans will vote for a Clinton-style piece of legislation. There are 4 of us who are Democrats that are no as well, so that makes 21. You only need 1 other person. There are 3 who have not decided. 1 other person would keep anything from coming out of that committee because it would be a tie, 22-22 at that point. And I do not at this time see any of the 4 of us changing our mind about where we are. And the chairman is not able to get one of the other 2 or 3 people to vote for what he would like to get out. So it appears at this point that nothing is going to come out of the Energy and Commerce Committee, which means the Rules Committee in the House is pretty well going to make the decision about what's going to be on the floor. Mike and I have kept our bill strictly bipartisan. There's 70 people on it now, 35 Democrats and 35 Republicans. We think that that's what we have needed to do to show that we've got good bipartisan support for the piece of legislation that we have proposed. It's hard to know what's going to happen at this point. If the Senate Finance Committee is able to report out something, I think that will give a little more emphasis to trying to do something on the House side, and they would need to do that before we start the August break, which starts after the first week in August. The July break starts at the end of this week and goes through next week. When we come back, something will have to be written, I believe, during that period of time if we're going to do all of the things that would be necessary to have conference reports and get back to a final piece of legislation. Earlier I had felt that we would pass something this year because I think that Congress thinks that the public expects something to be passed. There's been so much attention focused on this issue that if something is not passed, I believe that members of the House and Senate thinks it's going to be bad politically for those people who are serving in the Congress now, the administration as well. So that is an impetus to try to get something moving along. So that's where we are at this point. We'll see what happens with the Senate Finance Committee this week, whether or not they're able to move forward. Mike and I are continuing to look for additional co-sponsors. It's possible that we may open our bill up for for anyone to sign on to it, wants to. Mike has a whole list of Republicans who are waiting to get on it, but we would not put another Republican on until we had another Democrat. But we may possibly open that up. We're just going to have to sort of feel our way with that and see what happens. If we have a large number of co-sponsors of this legislation, more than any other piece of legislation out there, that the Rules Committee may have to look at us to the extent that they may have to let us bring something to the floor. I don't know, because they pretty well control it, and the leadership in the House on the Democratic side is very much opposed to this, as is the administration. So let me just stop right there and see if I can answer any questions that you might have.
It strikes me that your legislation would resolve about 2% of the problems that most people have with the healthcare system. What's the Clinton administration's problem with it? Not about taxes, not about bureaucrats. What's their problem?
Well, the problem they have is they say if you do this, then you may not do anything else. You may just stop right here and not move ahead with universal coverage. You know, the President has really made that the focal point almost of his administration for this year, and it would be, they believe, politically not good for them if that were to happen.
Under your bill, Congressman J, would Medicare and Medicaid be restructured through the community health centers, or how would you handle Medicare?
We don't make any changes in Medicare at all. Other than to address the fraud and abuse aspect of it there. We have federal Medicaid money come back to the community health authorities on a capitated basis rather than the way that it now comes. It comes to the state and then goes to individual providers on a fee-for-service basis. So that is the only change that we would make.
I've heard a lot about universal coverage, but not much about taking care of starving costs. I think most of us Americans who take care of ourselves resent the fact that we would be paying for people who do not take care of themselves and will not take responsibility for their health. And that health care is not a right. It's never been a right in our Constitution. It's our individual responsibility. Congress is getting more and more power today over the rights that we should be taking care of ourselves. A good example is my son was in the hospital for 20 hours in Florida for food poisoning. The bill was over $5,000. And there's no way in the world anybody can justify that. And none of your comments have been on the cost.
We hope that the community health center, as I mentioned earlier, there's a great deal of abuse in those two federal programs that we now have. We hope that those community health centers, who will treat a lot of the Medicare and Medicaid patients, will do a significant amount to hold down the cost. Of course, we have this fraud and abuse legislation as well. I believe that if we can put community health centers in place, we can stop some of the cost shifting, that we can go a long way towards addressing the increasing cost of care. We've got to look at the reasons for the increasing cost of care in our country other than the abuse of the system. The fantastic technology that we have now is very expensive and unbelievable, really. Who would have thought 25 or 30 years ago that they would be doing organ transplants? There is a malpractice problem as well that adds a significant amount that we try to do something about here. Cost of care is caught up in inflation, like everything else is. So it's gone up from those standpoints as well. I know that I, as an individual practicing medicine, when someone came to the hospital that was really sick, it was not like going to buy an appliance or an automobile where you may accept a medium price appliance or a medium price automobile. The family said, I want the best. I want the very best, and they do. Health care is a little bit different from the retail market. It's a very complex problem, but I think we ought to do these kind of things that we're talking about, and let's see what that does to hold down the cost of care. I know there's a lot of activity now going on in the business community, working out relationships with health care providers to try to do just what you're talking about, hold down the cost of care. And my understanding is that the increasing cost in many instances have come down from 15 to 20% a year down to 3 or 4% a year. So I think there's a lot of realization about the high cost of care and how ridiculous it is, and a lot of things are being done to try to hold down the cost of care. I just don't believe that cost controls and price controls will work. I mean, we've had so many experiences with that in the past and knows what. That is one of the problems we have is the high cost of care. But let's try these things and see how they work.
As a follow-up to controlling costs, how about unleashing the consumer on the healthcare market by phasing out third-party payers for routine medical expenses, which would be the health IRA concept for the routine expenses, and then just have the catastrophic coverage for the major.
You mentioned IRAs.
Health IRA.
Yeah. I've had a piece of legislation in 3 Congresses on IRAs to allow for the purchase of long-term care insurance. We haven't had long-term care insurance around very long. We're just now beginning to get that. But I'm a strong believer in the individual retirement accounts and allow that to be tax deductible for the purchase of insurance. I think that's right. You mentioned the third-party payer relationship, and that's true. You know, that started back during World War II when companies were looking for ways to, they couldn't raise the salaries of people then because they wanted wage and price controls, and so they started doing things to give more benefits, and that's when we started with this employer involvement in providing health care. It's a system that we've gotten into, and I don't know how we'll get out of it. I think it'd be very difficult. I just don't think we'd get out of it unless we did something that, like Jim McDermott wants to do, who, by the way, is the other physician in Congress. Jim is a psychiatrist. I told Jim, I said, you know, I've always thought you had to be a little bit off to be a psychiatrist, and since you've introduced that bill, I know that you are. You know, he's for the single payer system. He's really a good guy. But we've got those kind of things in our system that, you know, you're really insulated from the cost of care if you've got insurance until you go to pay the premium, and if your employer is paying the premium, then you're totally insulated from it. So that's one of the flaws that we've got in our system.
Have you ever looked at the possibilities of, we're still overlooking a group of people in this country that many of which had well-paid jobs, had good insurance coverage a few years ago, and have since lost that coverage because of losing their job or whatever. Now they're taking menial jobs, anything they can get along with their spouses in so many cases, trying to just live from day to day. And this is the group that really does not have any type of coverage. And here we sit with workman's compensation, which is one of the biggest ripoffs in this country. We could, if we could get a policy for every family and couple it with a disability clause for the breadwinner in that family, we could literally wipe out any need whatsoever for workman's compensation. Now, I was told by a young lawyer that wouldn't work. It also protects the employer. Well, I've been paying for workman's compensation a lot of years as an employer, and I haven't seen it protect me yet. I think it's a ripoff. And we could take that amount of money and apply it as an offset to the cost of health care for everybody. Has anybody ever looked at that?
Well, I want to get involved in the workers' compensation issue, which is controlled mostly by the state. You know, and I'm satisfied to just leave that with the state. We do require, there's one mandate that we have in the legislation, that is that employers provide access to insurance for their employees but not have to pay for it, and then we have a catastrophic plan as well. Somebody else mentioned catastrophic insurance. There are a lot of people who have hospital insurance that will only go so far. A lot of people who have hospital insurance are very uneasy that they would deplete the amount of benefits in that, and then if they had a real catastrophic illness, they would be in a great deal of difficulty depleting their assets. So we do require providing catastrophic insurance as well, and have looked at the possibility, although this is not in our legislation, is one of the things that we can add to have catastrophic insurance with a very high threshold, maybe $12,000 or $15,000 as a threshold to pick up to help those people who now have insurance that would not cover all of their expenses. So that's another possibility about something we're looking at.
Dr. Rowland, you mentioned in your bill here that small business insurance marketplace reform is included. Can you give us some details on reform and suggestions?
As I mentioned, we do require that everyone every employer provide insurance for their employees. We say that there would be some small market reform in people who employ 2 to 50 people as well. Let me send you the details on that. Here, if you will give Bill Stemridge your name, we'll give you the details on that. One more question.
I continue to be amazed at Ed Recruit's wholehearted endorsement of
I mean, the president, what did he put? I'm not sure I understand.
Former Surgeon General. He has a total endorsement of the plan. He keeps talking about.
Are you talking about Coop?
Yeah,
Why did he endorse it?
yeah, and
Yeah.
what's his input, what's his stand on it, what has he done here?
I don't know, and I was really amazed when the Surgeon General did that. You know, that he approved the president's plan. If you recall, when the president came to the Congress to make his presentation, that Dr. Coop was sitting next to Miss Clinton. That was a real odd combination, I thought.
Tom Brokaw had a program on last week, and he's continued this. He was the biggest endorser of the whole
Yeah.
program.
I haven't heard him. All I've heard is that he endorsed the plan, but I haven't really heard why. I'd be interested to know what.
I think sometimes the imagination or the illusion of influence
Yeah.
is corrupting his power itself.
Yeah, might be. Let me thank all y'all very much for the opportunity to be here this morning.